Next, we have Dr. Nseir, who's going to talk to us about thrombectomy for acute PE devices and the trials.
Good afternoon, everyone. So, a few months ago, we were in a quality meeting in my hospital, and one of the intensivists said, we need to organize the PE in our hospital. It's all over. A lot of people are involved in it, interventional radiology, interventional cardiologists, vascular, different kind of treatment. We don't know our data. We don't have any follow-ups. What happens to those patients? So we decided to start looking into the PERT program and looking into the data, what's available, try to organize ourselves in our hospital, and that's the basis of my talk. Conflict of interest is none. So statistic on PE, it's almost 1 million per year. It can be presented as sudden death in 25% of the cases. Up to 100,000 deaths per year, and long-term complication is close to 30%. Obviously, it's classified in severity. We all know about the high-risk PE described or characterized by hemodynamic instability, increased SPSE score, RV dysfunction, and elevated cardiac troponin. Intermediate and low follow the same characteristic. And I don't think there is a lot of argument about high-risk PE and how it's going to be treated. The intermediate risk PE, first of all, about the diagnosis and how it's going to be classified and the treatment. I think this is where most of the confusion is there. So intermediate risk or submassive PE is characterized by systematically normotensive with a systolic blood pressure above 90 millimeter of mercury, RV dysfunction, meaning there is myocardial necrosis, characterized by elevated troponin or increase in the RV-LV ratio above 0.9, either by echo or by CT scan. Also, there is a criteria with elevated BNP. EKG changes can be there, new complete or incomplete right bundle branch block, ST wave changes in the interoceptal leads. As all you know, the simplified PESI score is comprised of age, cardiopulmonary disease, cancer, systolic blood pressure, heart rate above 110, oxygen saturation less than 90%, and anything above 1 point, the 30-day mortality is around 11%. And this is kind of a spectrum. As soon as we start hitting in the intermediate low-risk PE, the mortality starts going higher, the 90-day mortality. In this category, intermediate low-risk is up to 15%, and the high-risk, intermediate high-risk is up to 30%, and in the high-risk population, it's up to 90%. So why is that? The RV, I always like how the RV is the orphan organ in cardiology. We've been all taught throughout the years, it's only a severe tricuspid regurgitation, don't worry about it. It's RV failure that will recover on their own. And the reality is not that. Once you have RV dysfunction and RV dilatation and increased RV afterload, you're gonna start the same spiral that we see in LV shock, and this will lead to increased RV oxygen demand, intrapulmonary AV shunt, more RV ischemia, decreased contractility that will affect the preload on the LV, decreased cardiac output, and we have an obstructive shock that can lead to even death. So we all agree that RV dysfunction is not good and something needs to be done about it. So let's go through the trials. I'm going to start by PITO trial. That was the basis of systemic thrombolysis. Years ago, they compared TNK to anticoagulation. They enrolled almost 1,000 patients, and they showed that all-cause mortality or hemodynamic collapse within 7 days is better with TNK. However, there was no overall mortality benefit at 7 days or 3 years. Also, TNK had higher major bleeding. There was different thrombolytic regimen. The most common one is used is TPA, or the only one that's used is TPA, 100 milligram over 2 hours. Catheter-wise, catheter-directed thrombolysis, we have different ones. The most common one that's used is the ECOS. And these are the summary of the CDL trial. And here we show it better. Start from Ultima back in 2014 to the knockout in 2024 that has progressed over the years with the duration and the dosage of the TPA catheter, and currently enrolling the HIPETO trial. Regarding catheter-based embolectomy, the most common used one are the flow retrieval from Inari and Indigo from Penumbra. If you put them side by side in a table, you can see that regarding efficacy, they're all the same. If you look at the RV-LV index change, they're all the same. Hemodynamic improvement, they're all the same. Bleeding events, initially, obviously with thrombolytic therapy, when they used the higher dosage, it was higher. Now it's better with the Optilase trial and the lower doses and the lower duration. Mortality also is equivalent. If you take a meta-analysis comparing catheter-directed thrombolysis versus thrombectomy, including surgical thrombectomy, overall, the mortality, there is a decrease in hospital mortality, mostly related to the surgical embolectomy. The major bleeding, a stroke, and need for blood transfusion were similar between CDT and thrombectomy. Hospital ICU length of stay and 30-day readmission were similar between CDT and thrombectomy. The FLASH registry was a prospective multi-center registry, including the flow retrieval. The primary endpoints was device-related mortality, major bleeding within 48 hours, and intra-procedural device or procedure-related adverse events. And all-cause mortality at 48 hours was 0.3%, 30-day visit 0.8%, and 6-month visit was 5%. Recently presented at TCT was the REAL-PE study, which is a data collection from a data platform called the Truvita. They compared PE treated with ECOS or flow retrieval. Safety event was in 7 days, included in hospital deaths, major bleeding, intracranial bleeding, and ischemic stroke. They had two cohorts, primary cohort and contemporary cohort. The contemporary cohort, this is when they start using lower doses of thrombolytic therapy. Patient characteristic, the flow retrieval group had a greater proportion of patients above age 60 or with history of cancer. Proportion of patients with anticoagulant use within 30 days were similar between the two groups. What it showed that there was 7-day major bleeding. There was an increase in the flow retrieval group in 7-day major bleeding and intracranial bleeding. The PERT consortium database, the data showed that still the in-hospital mortality in high-risk PE is high. The risk of bleeding is 3.7% in hospital for intermediate, and the bleeding for intracranial bleeding is 3.5%. So what are the current recommendations right now from the PERT consortium? Consider catheter-directed thrombolysis if you have intermediate high-risk PE with risk for clinical deterioration based on the vital signs, severity, or the RV dysfunction without absolute contraindication to thrombolysis. Consider catheter embolectomy if there is absolute or relative contraindication to thrombolysis or there is failure of thrombolysis. We have to note here that currently the interventional devices, the trials, they didn't show any mortality benefit. We don't have trials that showed mortality benefit. Instead, the study relied on surrogate markers for mortality, such as the RV-LV ratio and significant reduction in the RV-LV ratio. So what's in the pipeline? I will go briefly. We have the HIPETO trial comparing ECOS to anticoagulation, plus anticoagulation versus anticoagulation alone. The primary endpoint is 7-day composite of PE-related mortality, cardiorespiratory decompensation, PE recurrence. Peerless study comparing the flow retriever versus catheter-directed therapy. They're looking at all-cause mortality among other primary endpoints. PE tract comparing CDT versus anticoagulation. They're looking at the O2 consumption, New York Heart Association classification, and the risk of bleeding. And finally, we have the STORM PE trial, which is sponsored by Penumbra. It's a randomized trial comparing CDT with the Penumbra catheter versus anticoagulation. Finally, I know there is a talk about PERC, the impact of PERC involvement in hospital outcome and intermediate and high-risk pulmonary embolism. Through the PERC consortium, it showed significant shorter length of stay, significantly lower frequency of in-hospital mortality, and they had higher frequency of improvement in RV size. Thank you.